Good morning, everybody. My name is Chris Clark, and I'm the Program Director for the Masters of Athletic Training Program. So this is Cody Hopkins. He is going to be presenting on the lever sign and different aspects that go along with ACL tears. So he's a second-year student in the Masters of Athletic Training Program. So Cody, I'll let you take it.
Good morning, everybody. How are y'all doing this morning? Awesome. Like I said, my name is Cody Hopkins. I'll be briefly talking about the lever sign. The title of my presentation is the lever sign an effective diagnostic tool for the acute anterior cruciate ligament tears? So the ACL, or the anterior cruciate ligament, is one of the primary ligaments of the knee. There's 4 total. The purpose of the ACL is to prevent excessive anterior or rotational tibial movements relative to the femur. So the tibia is the top, the femur is the top thigh bone, and the tibia is the lower leg bone. So ACL injuries. The ACL can be injured through direct contact or non-direct contact alike, but it's more common through non-contact forces, such as pivoting or cutting movements commonly seen in sports. Like it's shown there is about 68.6 per 100 athletes. I'm not sure how to get 0.6 of a person, but about 69 people per 100,000 athletes have ACL injuries each year. And actually, female athletes have a higher chance of having an ACL tear than males. And on the right just shows what an ACL tear kind of looks like. So common diagnostic tools for diagnosing ACL tears. The best thing to do is the knee joint arthroscopy, which the clinician will actually go in and look with a camera. It's a surgery. The pros of this is they can actually fix it while they're in there, but it is the most invasive, can be timely and expensive to do. The next best thing for identifying ACL tears is MRI, or magnetic resonance imaging. It's highly accurate, it's less invasive, but it can also be costly and untimely. And then special tests, they offer a little bit more ease to use, and they're inexpensive. Clinicians can use these anytime. They're the least invasive of the 3. However, their accuracy can be inconsistent, especially among different clinicians. Patient factors may also alter the results of these tests. So why do we need special tests? So they allow for rapid assessment of the injured body segment or joint. They facilitate the injury diagnosis and treatment process. Special tests, they should be accurate so that you can get those plans in accordance in the right time frame. And the ACL injuries that go untreated or undiagnosed can cause further injury down the road and lead to complications in life. So some drawbacks of the common special tests. The most common special tests are the Lockman, anterior drawer, and pivot shift. However, all of these require quick translational movements that may cause patient factors such as pain, swelling, apprehension, and they are also limited by those factors. They have been shown to be inaccurate in detecting partial ACL tears. So proposed benefits of the lever sign. How is the lever sign better? It's proposed to be unaffected by these patient factors that I previously mentioned by utilizing forces that do not contact the knee directly. It's proposed to be completely accurate in identifying both complete and partial tears alike. So this picture kind of shows how you perform the lever sign. So the clinician balls it in one hand, places it under the calf, and then he presses down on the thigh of the person's injured leg. The heel is observed. If the heel rises off the table, the ACL is thought to be intact, and if it does not rise off the table, the ACL is thought to be torn. So the focus clinical question of the study: when clinically diagnosed patients with acute ACL injuries, is the lever sign more accurate than the other common special tests? So in the PICO format, the patient population is patients with possible acute ACL injuries. The intervention is the lever sign. We're going to be comparing that to both the Lockman, anterior drawer, and pivot shift, and the outcome is diagnostic accuracy. So for the search strategy, I used 3 different databases: PubMed, EBSCOhost, and Google Scholar, and I utilized the search terms acute ACL injuries and all 4 of the special tests: lever sign, Lockman, anterior drawer, and pivot shift. So inclusion criteria, I wanted it to be written in English and posted in the last 10 years to be peer reviewed, to contain all the search terms and be predominantly focused on acute ACL injuries and not necessarily chronic. So articles for the excluding criteria, the articles that, like I said, focused solely on chronic ACL injuries were excluded from this, and then ACL injuries that had other ligamentous or soft tissue damage were also excluded. And then any unrelated topics to the ACL. So from those three databases, there were 224 total results, and those were wired down to 4 total studies selected from those. So the evidence quality assessment, I used the Strobe analysis for cohort studies and found that the study by Guppenar et al. Had the best quality assessment, and the study by Lely et al. Had the worst quality assessment. So let's talk about these studies real quick. So the first study is the original study by the creator of the test, Alessandro Lely. The findings of this study was that the accuracy of the lever sign is not impacted by the stage of injury or the severity of the injury. So in both acute and chronic tears, and both partial and complete tears, it was 100% accurate. It showed that the patient factors were not an effect of the lever sign, and that the lever sign is the perfect agreement between the MRI and the clinician's findings. So the second study, this one focused on a single sport, skiing. ACL injuries are common at ski resorts. This study also included the highest female participant population at 190. Like I said, females have a higher incidence rate, so it's important that they have a higher inclusion in the study. The key findings of the study was that the allotment is actually superior to the ACL, to the lever sign, and that the lever sign should only be used as a supplemental test and not a standalone test. The sensitivities of each were 61.2 for the lever sign and 99.1 for the allotment. So the third study, this one was a little bit more broad and focused on different aspects of the lever sign. It looked at the overall accuracy. It looked at the effects of anesthesia. It also looked at whether male or female participants had various accuracies. And then it also looked at the clinician's skill level. So if they were students or if they were orthopedic fellows, more trained individuals, how that would impact the lever sign. So all of these were relatively same between each subcategory. So anesthesia was unaffected by the lever sign. And then the gender was relatively the same as well. And as far as the clinician skill level, that it did not very much affect the accuracy of the test. And then the fourth study, the purpose of the study was to determine the accuracy of the lever sign across different stages of injury in a particular subset of participants. So it followed a group of participants from the acute, chronic, and post-reconstructive stages of the injury. And it found that the accuracy of the lever sign is unaffected by the stage of injury, the anesthesia, and patient factors like the previous study found. It's the only study to find that the rigidity of the examination table played a factor in the test. And it found that 91.9% sensitivity and 93.8% specificity. So the clinical bottom line. So the lever sign is a viable option for ACL special testing. It should only be used in conjunction and not necessarily a standalone test. With varying reported accuracies among the 4 studies, had about 82.5% average across the 4 studies shown. It's shown to be unaffected by anesthesia, clinical expertise, and patient factors, and has an easy learning curve so that anybody can do it. So the implications, like I said, this test has an easy learning curve, so anybody at any skill level can perform the test. Special tests, including this one, allow clinicians to make accurate and expedited decisions regarding the injury process, and that correct immediate management is very important to the health and well-being of the patient. So further research is needed to confirm whether using the standard Bridges table, like the 4th study found, is accurate across different studies. Also to include higher populations, especially with female representation. Only 1 study had high female representation. And then another thought process was to determine if the clinician hand size has an effect on the accuracy of the test. Somebody with a smaller hand may not be able to produce a full palm like somebody with a larger hand. here are the references. I also want to say thank you to you guys for allowing me to speak. Thank you to my classmates and professors for all that you've done.
Questions for our speaker?
I have a question.
Yep.
Why do females have a higher ACL injury rate? Is there a noted reason for that?
So it's something called the female athlete triad that kind of affects how they are able to respond to different injuries. They have more, let's see, so they have a higher chance of ACL injuries because of the decreased,
Okay.
basically the female athlete triad is why they're more susceptible to ACL injuries.
Got it. And so you alluded to the rigid table.
Right.
Is it the thought that maybe if a less rigid table were used, that you might have a more accurate, or?
So a more rigid table would actually produce a better
Okay.
test, because if the table was soft,
Yep.
the hands that they're pressing into would be less able to produce the fulcrum.
So a rigid as in this rigid?
So yeah, so a
Okay.
hard, like a table like this would
Okay.
produce better results.
Okay. Well done, thank you.
All right, let's thank our speaker.